So the afternoon, we have so many amazing doctors presenting on topics that I know address a lot of the questions we hear through the NMOSD helpline and in our support groups. So the afternoon session is Empowered Living, Clinical Insights for Improving Quality of Life. And our first presenter is Dr. Yangmeo Dreyer from OMRF. If any of you were in Oklahoma City with us or watched online, she was there as well. And they have an amazing lab they gave us a tour of. It was beautiful. So we're so glad that she made the trip to Dallas. And we'll welcome her to speak. Thank you.
Good afternoon. Can everybody hear me okay? Hope you had a good lunch. How do I get the slides up? I'm going to start with the story. How do we do the slides? Thank you for sharing the journey together. Actually, I do have an analogy to draw for the journey that we all took together. I just have to start with the thank you, Corey. Thank you for our organization. Nice to see Jacinta and Dan. So last time we were in Oklahoma City last year. Yes, so the journey took me from Oklahoma City to Dallas by flight. It was 30 minutes, but from my terminal to the hotel, it took me more than that long. Talking about journey, I should have taken the offer. Corey offered to have a shuttle take me. I should have taken that offer. It just, my scientific brain was thinking about this, how to talk about autoimmune disease and make an analogy, okay? So I was thinking, oh, sure, I've seen Grant Hyatt before. You know, I've been to Dallas so many times. I take Skylink. So I went to Grant Hyatt. I guess I wasn't looking at Corey's instructions. I figured how many Hyatt could there be? Anybody has done mistakes like me? Oh, okay. So I'm not feeling that bad now. So talking about autoimmune disease, I have to talk about your body mistakenly attack organ that's supposed to be part of a normal organ. So that's what happens for autoimmune disease. There's a little mimicry. So Hyatt, Grand Hyatt and Hyatt Regency. So it got a little epitope similarity. That's what I figured. So that's my analogy when I'm thinking about this. But next time, if Corey offers shuttle, I'll take the shuttle. Okay, I literally walked through the parking lot. I thought, how hard could that be? I can see it. But I'll tell you, that journey is long. But anyway, that's my glory today. If I can figure out how to fast forward the slide. Okay, so my task today is to talk about NMO and MS. How are they similar to each other or different? So we all know they're all autoimmune disease. Like I mentioned, what is an autoimmune disease? Your body mistakenly attack part of the organ supposed to be normal. So there's always a target organ. In this scenario, brain, spinal cord, optic nerve are our target organ. They're mediated by inflammatory cells. I'm going to talk about different cells. Dr. Yemen gave a fantastic talk and made my job easier. But both of disease can cause optic neuritis and transverse myelitis. I'll explain those too. And both disease can give relapses. Both need long-term immune therapy. But there are a lot of differences. So I'll focus on some of the differences, starting with what's the target in neuromyelitis optica. It's the astrocyte. I'll show you a diagram. But in MS, the target cells is actually wrapped around the neuron, myelin. And so here's a diagram. I'm trying to really simplify more so than probably Dr. Yemen's slides. As we all know, there are trillions of neurons in the brain. So you heard about neurons, those are the purple cells, so you can see there. But the light pink cells. but the purple cells are your astrocyte. Those are the supporting cells, kind of supporting the neuron growth. And the wraparound are oligodendrocytes. So those are the three cell types in the brain that govern how we think, we behave. So imagine the connection between neuron and neurons are not talking to each other, then you can have various type of symptoms. But the supporting cells, astrocyte, are critically important. You can see it kind of lined up the blood-brain barrier area. The food processes express a water channel called aquaporin 4. Okay, so in this scenario, in NMO, aquaporin 4 is being attacked by immune system. So the three component, I'm gonna make it simplified, that drive this disease process, as Dr. Yemen pointed out. One is the B cell, because they generate aquaporin 4 antibodies. And the second is complement. Complement binds to aquaporin 4, and it actually punches a hole. There's a complex, complement complex that punches a hole to destroy astrocyte. And then there is the cytokine component, interleukin 6, as I had red circle there. So in NMO disease processes, those three bad players kind of orchestrate the attack to the astrocyte. So that's why NMO is a disease affecting astrocyte, but MS is more of the disease affecting oligodendrocytes. As you can see, it's a wrap around the neurons. And for MOG, and I cheer you up, who was able to, Andrea said that. Okay, if I can get this straight, it's a myelin glycoprotein associated. Yes, MOG, let's just say MOG. So MOG is actually located on oligodendrocytes. So if you have a target of oligodendrocytes, you would have a demyelination, and also bystanderly, you would destroy it underneath the neurons. So those are the cells that could be the primary targets, or we call bystander disruption because they're neighboring cells. So those three cells are kind of intertwined in the brain, and underneath the tissue disruptions, it depends on where the changes happens. That's where you experience different symptoms. But it tends to be both disease or we can talk three diseases. Sorry, I mostly focus on neuromyelitis optica. I'll start with the neuromyelitis optica. It's very rare compared to MS. So roughly around 100 patients I see with MS, so only one would have an NMO. So that's how rare it is. If you're not in major MS centers, so community neurologists, so they don't hardly, probably, like a lot of neurologists I heard about education need to hear about the disease because it's so rare. Some of our colleagues have not heard about it. So now the education have gone to, I really like this program because it really educates patients, providers, and the physicians as well. So in US, there's actually a total of 4,000 patients only. Worldwide, it's 1 to 2 out of 100,000 patients. And it's predominantly women. I probably listed wrong. It's out of 10 patients, 90%, it's 9 patients will actually be women, and 1 is man. You can just imagine. And race and ethnicity affect the disease a lot. Most of NMO patients are actually African Americans and Asian. They're disproportionately affected more. And used to be, we 10 years ago, not long ago, actually, 10, 20 years ago, NMO used to be lumped as a part of a variant of MS. You know, we can call it bad cousins of MS, but it's really didn't separate out as its own disease until the aquaporin 4 antibody was identified by a group in Mayo Clinic, Dr. Lennon and Sean Peacock, they all contributed discovery of the antibody, and it's really intriguing that it helps to diagnose the disease. And when we look at a patient, you can see the picture, I put it here on the right. You can see in the middle of the spinal cord, there's a white strip. That's your longitudinal expanded spinal cord. It's not supposed to be this swollen. So you can see that's your longitudinal transverse myelitis. Usually MS does not present this way. I'll show you MRI of a MS patient. But for optic neuritis, it's also very involved long segment optic neuritis. So also the attack in NMO is different from MS. It's a lot more severe and it's less responsive to IV steroid. And usually, you probably noticed that we would have to escalate to other therapy during acute attack. And usually there's also less recovering from each relapse. It's really important to recognize the disease. As we know, there's an NMO-specific treatment. And old days, we used to use MS therapy to treat NMO, but that really make NMO worse. And such as type 1 interferon. I don't know if you heard about interferon, Ivanax, beta seron, rebif. How many of you were misdiagnosed with MS, by the way? To diagnose with MS to start with. I'm surprised less numbers, but many years ago, a lot of patients were treated with the MS drug, like Ivanax, beta seron, Pлаготи, but those make NMO worse. So then that's why recognize the disease is really important because the optic neuritis attack and transverse myelitis attacks are a lot more severe. And then there's also a unique NMO-associated syndrome called area post-Raymond syndrome. It associated with intractable hiccups and nausea, vomiting. This is even harder to be diagnosed. Lots of patients end up going to ER many times before they're recognized. They've been sent to a gastroenterologist or GI specialist and go through round and round of checkup. And so it took usually a decade sometimes to be diagnosed in old days before the test become available. So, but different from MS, MS tends to have more cognitive impairment. NMOSD has less of cognitive impairment. So those are the clinical manifestations, but demographically, like I mentioned, NMO is a really rare disease. So only 4,000 in US. And compared to MS, like I said, I can see 100 MS patient, and maybe there's less than one NMO patient. And worldwide, there would be 30 to 300 per 100,000 for MS. And again, both diseases affect women more so, but for NMOSD, it has higher women to men ratio of 9:1 versus 3:1 in MS. And also, NMOSD affect age onset is slightly older than MS. So MS roughly, majority of people diagnosed before age of 30. But for NMOSD, most people diagnosed around age of 40. So like 10 years older usually than MS. Ethnicity, as I mentioned, Asian and African American get affected more. So the incidence, if you look at the different country or geographic, you will see the incidence rates will be higher in Asian countries than Africa. So pediatric cases is very rare in NMOSD, more common in MS. But you hear from Dr. Cindy Wang later, maybe it's more of a recognition, maybe pediatric cases also on the rise. And thanks to the diagnostic tools we have. And in terms of the diagnostic findings, and I wanted to just show you the picture again, you can see the differences. And in terms of brain changes in NMO, it's relatively rare. And also the characteristic of a brain changes are different than MS. And spinal cord, you can see the white strip among the black part of the spinal cord. That's we call longitudinal segmental transverse myelitis. So but MS lesions a lot shorter. And MS tends to have this, you see the pig defense structure, the Dawson's finger on the side of the brain pictures, but this is a classic for MS, but you don't see that usually in NMO. And I just want to show you a couple of pictures. You can see across the room. Okay, for MS, there's a McDonald diagnostic criteria. And you can see usually MS lesion in the brain tends to be oval-shaped and asymmetrical. They can be in different part of the brain. But you can see they're usually smaller and than what you would see in NMO lesions. Those are different locations. We talked about the gadolinium, you get the contrast when you go do MRIs. So some can be brain-enhancing, some may not. And then you have what you call juxtacortical, is near the surface of the brain, as well as deep down as a paraventricular lesions. So you might see those with typical classic MS. But brain abnormalities used to be regarded impossible in NMO, but it's not true. Then after people looking at it closely, especially Mayo Clinic group, and they actually found MRI brain changes could occur in NMO, but usually take a little longer time, 6.5 months based on this study. And you can see what I showed you earlier. The brain lesions for NMO are looking a lot different. So you can see those fluffy white spots. Those are the cerebral lesions that could occur. And the location of those lesions are different. They can be more in the deeper brain tissues called thalamus and diencephalon regions, the second row. And thirdly, the spinal cord and brainstem can be affected. Brainstem changes can occur, cause incoordination, and the diencephalon lesions can cause even endocrine abnormalities or sleep disorders. And the cerebral, of course, people can have seizures because there's a lot of different presentations we realized, and it just need for our residents, we train them, they just need to keep their mind open. So we'll just need to be tested patient more often for the antibody when you see unusual MRI changes. And in terms of laboratory diagnosis, as I mentioned, aquaporin 4 IgG antibody that need to be tested for suspected cases, and 90% are positive in NMOSD. MS, you won't see this antibody at all. And in terms of the assay we use, we call cell-based assay. That's the gold standard, and usually sent out to Mayo Clinic. So, but we also often use spinal tap. I don't know if you had one before. It's not really that pleasant to go through. But we really look at the data closely because the spinal tap can give you a lot of information. So we look for something called oligoclonal bands. It's actually very rare to have positive oligoclonal bands in NMO, but MS 95% will be positive. And we also look at the cell counts, and we call it cell counts and differential. So in NMOSD, you would have a little bit elevated white blood cells and proteins, and usually it's more of a neutrophil predominant. But in MS, usually you have perhaps a mild elevated cell counts, but usually it's more lymphocyte predominant. So I want to show you a picture. What is oligoclonal bands? Because most people come to my clinic usually actually ask me that. It's just hard to understand. So the way that it's run, you have one side is the CSF samples, the other side is your blood. So you actually compare side by side. And so I don't know if you can appreciate the normal side versus abnormal. So there's the banding of the CSF. But so you can see the differences that is unique to spinal fluid. But this is a scenario we see more often in MS again. In NMO, you can have normal a spinal tap. You can have no oligoclonal band. It doesn't mean you don't have the disease. Okay, so again, the clinical course, this is before FDA-approved treatment was available. Study was done 20 years ago. So I just wanted to know the outlook for the disease has changed dramatically. It used to be once you have one attack, you can be completely debilitated and the recovery is really, really low. So, and the mortality is super high. But the outlook has changed dramatically. This is a slide to show in older days before treatment. Again, I wanted to summarize what I have talked about. The clinical presentation, NMO patients tend to be older and have more severe optic neuritis and transverse myelitis. And it's very rare with familial cases. And it tends to be very debilitating, as I mentioned, before treatment, and affect African Americans and Asians more. And the relapse can be very, very debilitating. And diagnostically absent of oligoclonal bands and aquaporin 4 IgG antibody, cell-based assays, very, very specific for diagnosis. And imaging-wise, you have longitudinal transverse myelitis as well as bilateral optic neuritis. So why we're talking about the differences between NMO and MS, as alluded early, MS treatment make NMO worse. So we really have to be able to differentiate the two diseases. In old days, we treat MS with type 1 interferon, Avonex, Plaguety, beta seron, Rebif. But if you see the dots here, on one side, it's before treatment. After you start interferon beta, you see the density of the dots are increasing. So interferon beta actually tends to bring on more relapse. So our lab actually studied this phenomenon, trying to figure out why. We actually have done something called a proteomic analysis. We have a group of patients who has aquaporin 4 positive NMO, and then we compare it to MOG IgG positive NMOSD, and then also seronegative NMOSD. We found different pathways. Interferon, type 1 interferon pathways is elevated in aquaporin 4 NMO, and also T follicular cell and B cell chemokines are elevated. CXCL13 is very important chemokine that mediated T and B cell crosstalk. But for MOG, you can see it's a granzyme that's more of a cytotoxic phenotype that it seems to be more predominant in MOG. And Wnt pathway, it's involved in spinal cord regeneration, degeneration. It seems to be more prominent in seronegative NMOSD. This area still needs a lot of research. We don't have a clear diagnostic tool for seronegative NMOSD. So in terms of a treatment landscape, I think Dr. Yemen already alluded, you all have experience for acute relapse. So usually you get steroid treatment. But again, it's different from MS. The steroid does not work that well. So we may have to escalate to plasma exchange and IVIG. You probably have that experience with plasma exchange. You have like a big dialysis machine, all of that. So I heard a few of you talk about it this morning. It's pretty daunting and scary to have that huge machine roll in the room. I totally understand what you have gone through, but that's kind of necessary because steroid does not work that well. And in MS, early stage of MS, most relapse would respond to steroid really well. So it's recognized the disease is really important, so then you can get plasma exchange treatment. Actually, the acute trial for management of NMOSD, we're looking at early plasma exchange treatment, and sooner will be better in terms of long-term outcome. So acute treatment is critical, as we know the relapse can be very debilitating. So in terms of maintenance treatment, like Dr. Yemen alluded to, we have 3 major targets. One is the B cell, as I showed you earlier. That's the type of cell that generate aquaporin 4 antibody. So the drug, old days we used rituximab, and now FDA approved inebilizumab, Uplizna. It's targeting CD19, which is on B cell. And the second target is a complement. That's the one that binds to aquaporin 4 and punch a hole on astrocyte. So there are two drugs that Dr. Yemen mentioned, is eculizumab and revolizumab. And the third drug is blocking IL-6 pathway. So it's anti-IL-6 receptor monoclonal antibody in spring, satralizumab. And some of you presented earlier this morning. It's really remarkable to hear you all have a great experience with those treatments. And I just want to point out this has significantly improved the patient's quality of life. And also, the outcome is a lot better than old days. I just wanted to summarize. I hope it's not too much information. And the take-home lesson is that we all know NMO, the target cell is astrocyte, those supporting cells in the brain, spinal cord, and optic nerves. And just accurate diagnosis is critically important, as MS treatment can make NMO worse. And so especially our group have done scientific work and looking at interferon pathways. We showed that the signature of interferon pathways actually elevated in NMO. It is associated with a disability. So we're hoping to study more of a fluid biomarker or B-cell, T-cell changes in NMO patient to correlate that with disease activity. And so all of our patients are helping to contribute samples to our research. So I think understanding what predicted disease activity, either attacks or recovery, would help optimal management of a patient and also guide future therapies, such as tolerance therapy and cell therapy, maybe which may be coming in next decade to come. Thank you so much for your attention.